Conditions of Childhood and Adolescence. Module 2, Disruptive Behavior Disorders. These are not just behavior problems. They are disorders of regulation, impulse control, and emotional response. You must distinguish between oppositional defiant disorder, conduct disorder, and ADHD because your intervention depends on it. Oppositional defiant disorder is marked by persistent defiance, irritability, and argumentativeness. The key distinction is that these children do not violate the rights of others. Nursing care focuses on consistency, avoiding power struggles, and setting clear limits. Per the DSM-5, oppositional defiant disorder requires 4 out of 8 behaviors for at least 6 months. Frequent temper tantrums, excessive arguing with adults, actively defying or refusing adult requests, deliberately annoying others, blaming others for mistakes, being easily angered and resentful, mean and hateful speech when upset, and seeking revenge. Key distinction for NCLEX. ODD involves defiance toward authority but does not include serious violations of others' rights or societal norms. The child is oppositional but not dangerous. Treatment approaches. Parent training programs, individual psychotherapy for anger management, family therapy to improve communication, cognitive behavioral therapy, and social skills training. Conduct disorder is more severe. It includes aggression, destruction, deceit, and serious rule violations. These children are at higher risk for substance use, legal problems, and long-term personality disorders. Safety and accountability are priorities. NCLEX critical point. Conduct disorder carries serious risks, including development of antisocial personality disorder in adulthood, substance abuse, depression and suicidal ideation, teen pregnancy, and legal problems. Nursing interventions. Establish trust while maintaining firm boundaries. Provide clear behavioral guidelines with consistent consequences. Teach problem solving and coping skills. Monitor for depression and suicidal ideation. Use role-playing to practice handling difficult situations. Help child accept responsibility rather than blaming others. Children with conduct disorder are at elevated risk for long-term behavioral, social, and legal difficulties, especially when symptoms begin early and are untreated. However, early identification and structured evidence-based interventions, particularly those involving family systems, can significantly improve outcomes. ADHD is a neurodevelopmental disorder, not laziness. It involves inattention, hyperactivity, and impulsivity. It must appear early and occur in more than one setting. This is a problem of executive functioning, not intelligence. There are 3 types of presentations, TOUNS. Predominantly inattentive type. Difficulty sustaining attention, doesn't follow through on instructions, avoids tasks requiring sustained mental effort, easily distracted and forgetful in daily activities. 2. Predominantly hyperactive impulsive type. Fidgeting, squirming, leaving seat when expected to stay, running or climbing inappropriately, difficulty playing quietly, talking excessively, and frequently interrupting others. 3. Combined type. Meets criteria for both inattention and hyperactivity, impulsivity. NCLEX key facts. Symptoms must be present before age 12. Must occur in 2 or more settings, home and school. Believed to be caused by frontal lobe dysfunction. Strong genetic component, more common in males. Nursing assessment for ADHD includes complete history and physical mental status examination, family and social history, cognitive assessment, and academic history with teacher input. Nursing diagnoses include anxiety, self-esteem disturbance, risk for violence, impaired verbal communication, altered family processes, and caregiver role strain. Structure is essential. Use short directions, reduce environmental distractions, shorten tasks down and provide breaks, focus on strengths, and use behavioral contracts with rewards for motivation. Stimulant medications can be very effective in improving focus, but I want you to think about them as just one part of the treatment plan, not the whole solution. First-line medications for ADHD are typically psychostimulants, such as methylphenidate, which you'll see as Ritalin or Concerta, and amphetamine-based medications like Adderall or Dexedrine. These medications help increase attention and decrease impulsivity, but they do come with predictable side effects that you need to anticipate and manage. The most common issue you'll see is decreased appetite, and that affects a large percentage of children. You'll also see difficulty falling asleep, especially if dosing is too late in the day, and over time, there can be concerns about slowed growth if nutrition is not adequate. This is where your nursing role becomes very practical. You want to teach families to give the medication after meals so it doesn't interfere with appetite. Encourage small, frequent, nutrient dense snacks throughout the day. Make sure doses are given in the morning. And if there is a second dose, it should be earlier in the day, not in the evening. You also need to monitor height and weight regularly so you can catch any issues early. For children who don't tolerate stimulants well, there are non stimulant options like atomoxetine, as well as alpha 2 agonists such as clonidine or guanfacine. An NCLEX important point I want you to remember is medication alone is not enough. If there is no structure, no behavioral support, and no consistency at home or school, the medication will not be effective. The best outcomes happen when pharmacologic treatment is combined with behavioral strategies and environmental support. Now that you've worked through disruptive behavior disorders, take a moment to reflect on what you've learned. You can now recognize the difference between oppositional behavior, conduct related risk, and attention or impulse control challenges. But in clinical practice, recognition alone is not enough. You will not be asked, "What is the diagnosis?" You will be asked, "What do you do next?" This is where many students struggle because in real situations, children don't present in clean categories. They present with overlapping behaviors, emotional distress, and safety concerns. So now we shift again. In the next module, we move from understanding disorders to making clinical decisions. You'll focus on prioritizing safety, choosing therapeutic communication, supporting families, and applying what you know in real clinical scenarios.